the truth is that paper 2 is usually one of the most important paper for your end of year. Now, you guys will be doing medical statistics, you'll do blood physiology, and you'll do all the 6 practicals that you've covered in year 2. So I can't really say that some practicals carry much weight. I'll be lying, because you might get a paper where we have more of hearing questions, vision, but be rest assured that they're going to balance every practical in that paper. So when you're studying, kindly take your time to go through them. However, today we're going to cover respiratory practical. Next week, probably on Friday, I'll create time so that we can go through blood physiology. So I hope to meet you guys again next week. Now, in respiration, these are very important and a very easy practical. Now, the objectives of our discussion today will be: number 1, we're going to talk about the spirometry. Number 2, we're going to talk about the FEV1 over AVC ratio. Finally, we have clinical examination, which I won't really talk so much about, but I'll try to talk about some 1 to 3 concepts about it. Now, let us start with spirometry. Now, from your lectures, you guys have been taught by Dr. Githinja about spirometry, and whatever you can see in the screen is basically an analog version of a spirometer. Nowadays, we have the modern forms of a spirometer. So what usually happens in this particular diagram, let me use a laser pointer. Now, this is called the mouthpiece, where the patient is going to put the mouth. Then you're going to tell you to do all sorts of inspiration and expiration. Now, what you notice is that here we have water, and here we have an oxygen chamber, and we have a floating drum. So whenever you breathe in or out, then we are going to have movement of this floating drum up and down. And as this drum is moving up and down, we can definitely have some drawings in the spirogram. So this is basically the analog version of the spirometer. Of course, nowadays you have the modern version. Now, the second thing that we're going to talk about today, that is now the most important thing in paper 2 respiration, is what we call the different lung volumes. Now, you guys have gone for your practical and you did spirometry. Now, in spirometry, we usually have this diagram and the spirogram, where we usually represent every types of volume. Now, guys, see, when you're breathing normally, you take in and out air, you take in and out air. This is what we call the tidal volume. The tidal volume is usually around 500 ml of air. Let me repeat. When you're breathing normally, you take in 500 ml, which is basically the tidal volume. But see, even though you're breathing normally, I can tell you to take a deep breath. So when you take a deep breath, you'll be also taking in some extra amount of air into your lungs. Now, this is what we call the inspiratory reserve volume. Now, the inspiratory reserve volume and the tidal volume together usually form what we call the inspiratory capacity. Don't forget up to that point. Take home message, you have inspiratory capacity. A capacity, anytime you're doing any question in paper 2 and you see a capacity under respiration, a capacity is basically a summation of 2 volumes. For example, inspiratory capacity is basically a summation of inspiratory reserve volume and the tidal volume. Now, I can tell you to breathe in and out, but again, I can tell you to forcefully expire out. Now, when I tell you to forcefully expire out, we usually have what we call the expiratory reserve volume. Now, when I take the expiratory reserve volume plus the tidal volume plus the inspiratory reserve volume, I usually form what is called the vital capacity. So in an MCQ question in paper 2, if you have been told the following are false about spirometry except, then choice A, the tidal volume is equals to, let me repeat. In an MCQ question you might get in paper 2, in an MCQ question in paper 2, they might ask the following question. The following are false about the spirometry except, then we have choice A. The vital capacity is a summation of inspiratory capacity and expiratory reserve volume. That one is correct. That one is correct. Now, the last point we're going to talk about is the residual volume. From chemistry in high school, you know that a residue is basically the remnant that remains in a given mixture. So even though you are able to forcefully expire air out of your lungs, there's a given fraction of air that usually remains in that lung that you cannot expire. This is what we call the residual volume. Now, guys, these concepts are usually very important as far as our discussion is concerned. The other point, the spirometry can never be used to measure the volume of the residual volume. because the residual volume can never be exchanged between your lungs and air. So it's quite difficult for you to use spirometry to determine the residual volume. But we have other methods like the helium method and the nitrogen wash experiment that have been developed to help in determination of the residual volume. Now, finally, when you take a summation of expiratory reserve volume and the residual volume, you'll get what you call the functional residual capacity. So these are basically the things you're supposed to know about a spirometer and the different volumes that are thus involved. Now let us continue to our next slide. So in this slide here, this is basically a diagram from Guyton and all comparing a man and a woman. So the tidal volume is usually 500 ml. The IRV is 3,000. I hope you guys can just take your time to go through these values here because they might actually come in your exams. So don't assume them. Don't assume them. Now, before I continue, there's something called a dead space that I want to talk about. You see, in normal inspiration and expiration, we will take the tidal volume, which is 500 ml of air. But guys, you need to understand at this point of knowledge that even though I'm taking 500 ml of air into my lungs, around 150 of that air is never exchanged, what we call the anatomical dead space. So the anatomical dead space is usually around 150 ml. Let me draw something for you guys so that you can see what I'm talking about. So let me use a pen. So this is your lungs. This is your trachea, sorry. Then this one is your bronchus. And here we have your lungs. So in tidal volume, you're going to take 500 ml of oxygen into the lungs. But around 150 ml of this 500 will never reach your lungs. Some of them will just remain in the trachea, the bronchus. In other terms, the conduit or the passageways for air. So 150 ml of oxygen, or rather of air, usually forms what we call the anatomical dead space. So in any situation or in any event, you get a question telling you to calculate the minute ventilation. The minute ventilation is usually the tidal volume times the number of breaths per minute. See, assuming a patient is having 12 breaths per minute and the patient has a tidal volume of 500, then the minute ventilation is going to be 500 by 12. But you have a different question. You might be asked by Dr. Awero that calculate the alveolar ventilation. Calculate the alveolar ventilation. Now, the alveolar minute ventilation is the amount of air reaching the alveoli. So for you to calculate the alveolar minute ventilation, you'll take 350 by 12 because 150 doesn't reach your lungs. 150 will remain in the passageways of air, what we call the anatomical dead space. Now, guys, that air that has entered your alveolus, all of it can never be exchanged into blood. It's basically a logic. Take, for example, this is your alveolus. Yeah? This is your alveolus, and here we have a blood vessel. So even if I have oxygen inside here, all of them can never diffuse into blood. A few fraction of them can actually remain in the alveolar. So the amount of air that remains in the alveoli that never undergoes gaseous exchange is what we call the alveolar dead space. So we have the alveolar dead space and the anatomical dead space. Never forget that for your exams, guys. It's a very, very important concept that you need to understand. Now, the last thing, physiological dead space is equal to anatomical dead space plus alveolar dead space. But in a normal person, the alveolar dead space is usually 0. It's approximately negligible. Let me repeat. Physiological dead space is equal to anatomical dead space plus alveolar dead space. So physiological dead space is equal to anatomical dead space plus alveolar dead space. But if a patient is normal physiologically, we usually say that your alveoli is totally healthy. So every air is supposed to diffuse into blood. That's why for a normal person, the alveolar dead space is equal to 0. And in a normal person, we usually say that the anatomical dead space is equal to the physiological dead space. Now, we can now continue. So now, I want us to go through some MCQs because this is the backbone of your exams. Now, we have this question here. Use the sketch of the spirogram below to answer the questions that follow. Then the volume of air in a normal breath is, I think I've told you, is the tidal volume. The tidal volume is actually the volume of air in a normal breath. When you're breathing in and you're breathing out, that's basically the tidal volume. Now, when you come to this diagram here, the tidal volume will be B. So this question can actually be set in another way by Dr. Awero. it might tell you to identify the volume of air in a normal breath. Then here you have choice A to B, you see C, D. So we need to know that the tidal volume is usually B. So if this MCQ is talking about the tidal volume, or rather, if it was talking about the part labeled B, all of them qualify to be the answer. Now, the next MCQ I want us to tackle is use the sketch of the spirogram below to answer the question that follow. The volume of air that is depicted H is, you see, all these questions are very, very important. Now, just go to where H is. I think you have said that H is basically the vital capacity. Don't worry so much about the background noises. Let us focus on whatever is going on. We are sharing knowledge, deep knowledge. So the part labeled H is what we usually call the vital capacity. So you need to know the parts and you need to know what they mean. Someone is requesting me to go through the dead space. I'll actually go through them at the end of the session, so don't worry. Now, the next MCQ that we're going to tackle is this one. Use a sketch of the spirogram, etc., which part represents the functional residual capacity. I've told you the functional residual capacity is equal to the expiratory reserve volume plus the residual volume. So you're basically going to take a summation of C plus E, what we now have here as F. Now the FRC is going to be F. That's how we usually answer these questions. Nothing complicated. I think now you can answer this question. The volume of air that can be exhaled after normal exhalation. Understand the question. The volume of air that can be exhaled after normal exhalation. After normal exhalation, you can only expire the expiratory reserve volume forcefully. That's why here choice is the correct answer. The next one here is FEVF. I'm going to talk about it in a few, don't worry. We are going to talk about the FEV1 over the FVC ratio. So if you know that you have a problem with that section, don't even exit the meeting before I reach there, because it's a very common thing in exams. I'm sure that you guys now can answer this question here, so I really won't belabor so much on them. You guys can answer this one. The vital capacity is represented by, I told you, the vital capacity is basically a summation. So it's A plus B plus C. That's basically the vital capacity. Yeah. Then we continue. Now, there's something that usually confuses so many people. And I'm really sure that even in this discussion today, there are so many people who are always confused about the FEV1 over the FVC ratio. So in our discussion today, I'm going to try as much as I can to solve your problem. Now, you see, the FEV1 over the FVC ratio is usually very important to make diagnosis of different lung conditions. You see, a patient might be having lung fibrosis, a patient might be having asthma, a patient might be having COPD. So these diseases are going to affect your lungs differently. Let me give you a good example. Now, lung fibrosis will make the lung to be fibrotic, and hence it will be less pliable. In other terms, if your lung is fibrotic and you inhale, your lungs won't be able to accommodate air because it will be losing the elasticity. And that is what we call restrictive lung diseases. A good example of a restrictive lung disease is what we call fibrosis. And you guys know the different types of fibrosis. Now we have what we call the cystic fibrosis, which I won't go into in this particular discussion. Now, an obstructive disease is basically going to interfere with the normal intake and outflow of air. The normal intake and outflow of air. That's basically an obstructive disease. And that's why a disease like asthma is an obstructive disease. So today we are going to understand how these particular diseases can affect your FEV1 over FVC ratio. And after discussing that, we're going to look into one graph that is very important for this particular concept. Now, even before, I think I've talked about these ones. So, yeah, this is supposed to be restrictive disease. I think I'll change before I share the slides. Now, guys, even before you come to whatever I say, I want us to enter physiology. Now, imagine we have this graph. We have this graph. I tell the patient to breathe in forcefully and then exhale. Look at that graph. Let me design it in a very beautiful way so that we can appreciate it. Now, oops. So we can have this graph. In this graph, I can tell the patient to take a very deep breath. The patient takes a very deep breath. Then it reaches a point, I tell the patient to do what? To exhale. The patient now does what? The patient exhales. Now, from the point where the patient starts exhaling, in my x-axis, I can have time in seconds. Time in seconds. Now, in this formula, we have what we call FEV1 and FVC. FEV1 is forced expiratory volume in 1 second. So how do you determine it in this graph? Come to the point where the patient started exhaling, let's say point A, then measure the volume that the patient will have exhaled in 1 second. So just come to the x-axis and look at the time, 1 second. Then you just come here up here, and you look at this volume. So this is basically the volume that the patient expired in 1 second. Now, assuming that here we have 0, here we have 2, and here we have 5 liters. So this patient will have exhaled 2 liters of air within 1 second. Now, this 2 liters is what we call the FEV1. That's what we call the FEV1. I hope you guys are okay at that point. The forced expiratory volume in 1 second. Now, the FVC is basically the forced vital capacity. Now, it will basically be the total lung capacity from this particular point here up to the 0 mark. So the total amount of this air here is what we call the forced vital capacity. Now, how do you calculate the FEV1 over the FVC ratio? You take FEV1 over FVC. Now, in this particular example here, assume that the FEV1 was 0 to 2, because we have said that it is the volume we expire within 1 second. So we take 2 over. What do you think will be the FVC? Will be 0 to 5 over 5 times 100. This will give you what? This will give you, I think 40. This will give you 40%. So for this example, your FEV1 over the FVC ratio is going to be 40%. Now, that is basically an example trying to demonstrate what you're talking about. Now, let us go back to physiology. The normal range, or rather the normal range of FEV1 over the FVC ratio is usually approximately 80%. Let me repeat. When you calculate FEV1 over the FVC ratio, you multiply by 100%, you're supposed to get 80% for a normal person, or approximately 80%. Now, when, sorry guys. Now, when the ratio is less than 80%, then the patient is suffering from an obstructive lung disease. Let me repeat. The normal FEV1 over the FVC ratio is approximately 80%. But when that ratio is below the normal range 80%, then that patient is suffering from obstructive lung disease, like asthma and COPD. Let me explain. If a patient has asthma, I'm asthmatic, so that's why I know this stuff. I'm asthmatic. So if a patient has asthma, so in asthma, we usually have constriction of the respiratory passageways. So if you have asthma, and I tell you to exhale, because of the constriction of your respiratory vessels, the patient won't be able to exhale a lot of air because you have resistance. I hope you're getting the point. Let me repeat. During asthma, we have constrictions of the bronchial vessels and even the trachea. So because of the constriction of the trachea and the bronchial, then we are going to have a high resistance in your respiratory tract. So if I tell the patient to expire air, that patient will have difficulties in expiring air. So if a normal person can expire 0 to 2 liters, then an asthmatic person can only expel, let's say, 0.5 liters of air because of that resistance. Now, when you come to this ratio here, it will be 2, let me say, x over y, where x is the FEV1 and y is the FVC. If you're asthmatic, the FEV1 is going to be much lower. And because the numerator goes much lower, this ratio is going to go much lower. And that's why in a patient who is asthmatic and who has COPD, or rather a patient who has obstructive lung disease, this ratio usually goes below 80%. The reason is because the FEV1 ratio is usually more affected than the FVC in an obstructive lung disease. So when you affect the FEV1 more than the FVC, the numerator is going to decrease more. And that's why that ratio is going to be also less. Now, I want to clear something from your minds that I know so most of you guys have in mind. During obstructive lung disease and also during restrictive lung disease, both the FEV1 and the FVC ratio will drop. All of them usually drop. But the FEV1 usually drops more in obstructive lung disease, while the FVC ratio usually drops more in restrictive lung disease. Let me repeat that sentence because it's very, very important. FEV1 and FVC, all of them are going to reduce in obstructive lung disease and restrictive lung disease. Both of them are going to go down. But in obstructive lung disease, even though both the FEV1 and the FVC are dropping, the FEV1 is usually more affected. So it usually drops more than the FVC. And that is why the ratio is going to be a smaller numerator over a larger denominator, giving you a percentage less than 80%. But in restrictive lung disease, because your lungs are fibrotic, then the capacity of the lungs to hold more air is going to be affected. And that is why even though in a restrictive lung disease, both the FEV1 and the FVC are affected, but the FVC is usually affected more in restrictive lung disease. Never forget that sentence. It will haunt in an exam. Now, the last sentence here is a ratio greater than 80% shows a restrictive lung disease. Why? You've said in a restrictive lung disease, the FVC ratio is usually affected more. So assuming you have X over Y, where X is the FEV1 and Y is the FVC. If I affect the FVC more, what do you think will happen to the ratio? The numerator will become much larger than the denominator, so the ratio is going to increase. And that is why if a patient is suffering from restrictive lung disease, a good example is lung fibrosis, then that ratio is going to be greater than 80%. Now we go to an MCQ question. I am going to answer the first part of the question, but you guys are going to answer for me the second part of the question. Now, the first part of the question is, study the diagram above which represents results of a spirometry in a 23-year-old medical student compared with a 35-year-old person with a diagnosed respiratory condition. Now, even before you continue, come back to your graph. We have two curves. You have curve X and curve Y. We have someone, a 23-year-old medical student who is purportedly healthy, but again, we have a 35-year-old person who is diagnosed with the disease. Now, it is common sense that the student will be curve Y, while the old person will be curve X. Why? Look at the vital capacity. From ear to ear. This is around 4 liters, right? This is around 4 liters. Now, meaning that for person X, the forced vital capacity is only 4 liters, while for curve Y, it's around 5.2. You can see where it's around 5.2. So when you look at this graph here, curve Y is for the patient, for the student, and curve X is for the diseased person. Why? Because curve Y is basically for a normal healthy person, and that's why the capacity is actually normal, around 5.2. So this curve Y is basically for the medical student. So here choice B is correct. Now, let us try to calculate the FVC ratio, guys. I want you guys to be very active in the chat box because it's a discussion, a virtual discussion for that issue. Now, let us start with curve X. I want us to calculate the FEV1 over the FVC ratio for curve X. Now, I told you the first thing to do is to do what? Determine the FEV1. So this is the curve for curve X, and here's the FEV1 in 1 second. So what we'll be doing in an exam, just join this one to the vertical axis. This is around 2.5, 0, 1, 2, around 2.5. So the FEV1 is actually 2.5, right? So it will be 2.5 over the forced vital capacity, which I told you that we now just take the total capacity, which is around 4 times 100. What do you get? Someone can just react in the chat box quickly because of time. What do you get? Amazing. We get 62.5. Now, that is the answer for curve X. Now, in an exam, guys, I want to teach you the trick of answering these questions. In case you're doing an exam and you get 62.5, a value of 60 again is correct because whatever we are doing here, we are approximating. You see, this y-axis and x-axis are not calibrated. So I can't really say that this one is 2.5 and this one is 4. But when you get a value like 62.5, even a value like 60 and 59 and even 64 can actually qualify to be the answer. Now, we've said that in curve X, the FEV1 over the FVC ratio is approximately 60%. Now, let us calculate for curve Y. The first thing is to determine the first expiratory volume in 1 second for curve Y. Now, I think it's around 4, right? It's around 4. So take 4, which is the FEV1, over 5.2. For FVC, what do you get? Times 100. Reactions mbio, amazing, 76.9, which is approximately 80%. You see here, we are basically approximating stuff. That's why you can't really be that exact. Now, let us look at choice A. As a tidal volume of 4.1, wrong. There's no way you can even determine the tidal volume from this graph. You can't even determine the tidal volume. Yeah. The patient has a FVC, correct. You can just come from 0 to 5 around 5.2. You see, someone can say that it's 5, but in an exam, just pick 5.2 because they are near each other. Someone, even if it was here 4.9, just take 4.9 because they're basically approximately to each other. Now look at choice C. FEV1 over FVC of 60%. Wrong. This one is for patient X, the 35-year-old person. It's not completely normal. Come on, this student is actually normal. I think I've seen from our calculations. It's represented by curve X. Wrong. Curve X is for the 35-year-old person. That's how we answer these questions. Now, the next part of the question, I want someone to answer this one. Any person to attempt this one, study the curve. Before we continue, I have a question. Patient X is suffering from which condition? Is it obstructive lung disease or restrictive lung disease? Chat box, please. You can just react there. Patient X. Amazing. You guys are actually getting it now right. It's obstructive lung disease. So take home message. Before you answer any question about FEV1 over FVC ratio in an MCQ paper 2, ensure you do the calculations. Ensure you do the calculations. So this patient X is suffering from obstructive lung disease. Now let us go to that, whatever question 49 is talking about. Study the curves. Yeah, the answer is choice D. The patient is suffering from airway obstruction. Airway obstruction can be due to COPD or asthma. So asthma, COPD will cause air obstruction, what we call obstructive lung disease. And that's why the correct answer for question 49 is choice D. Guys, I'm not a prophet, I'm not a witch, I'm not a wizard, but expect to find an identical question like this in your end of year paper 2. Expect to find such a question in your end of year paper 2. Don't call me a witch. Don't tell Waweru that, oh, he told us something here. They might end up throwing me away from PSC. But that's a take-home message. Now, I want to finish this class, but I want to talk about something that someone requested us to talk about. Now, for that, I think I'll use this space here. Let me just erase. Let me just erase. Be patient. Don't run away. Don't run away. I know some of you guys are very impatient. Now, I want to talk about the concept of dead space because it's usually very confusing to students. Now, this is your trachea. The trachea divides into the bronchus. And here we have the lungs. These are your lungs. You see, physiologically, the tidal volume is usually taken in and out per breath. So usually a value of 500 ml per minute. Now, it is logic and common sense that if I take 500 ml of oxygen here, not all of them will reach the lungs. Some of them will remain in the trachea and even the bronchus and the bronchial. That is what we call the anatomical dead space. So even though we are taking 500 ml of oxygen, only 350 is entering the lungs. Approximately 150 is remaining in the trachea, the bronchus, and the respiratory zone of the lung. That's what we call the anatomical dead space. The anatomical dead space is usually around 150 ml. So if a question asks you, the following are true about the spirometry or rather about respiration, except, then choice A, only about 350 ml of air enters the alveoli. That one is correct. 150 ml usually remains in the anatomical dead space, while around 350 usually enters the alveoli. Now, guys, I want us to come to this diagram to the right that I'm drawing. Now, imagine this is your alveoli, and this is your blood vessel in the lungs. So air is supposed to be diffused from the alveoli inside the blood. Again, in physiology, it's really interesting that Even if I have a lot of saturation of air here, not all of them can diffuse into blood. Not all of them can diffuse into blood. It's actually common sense. Not all of them can diffuse into blood. So because not all of them can't diffuse into blood, we'll have a fraction that will remain in the alveoli. That is what we call the alveolar dead space. That's what we call an alveolar dead space. An alveolar dead space is the amount of air in the alveoli that doesn't undergo gaseous exchange. That someone is asking for me to define the alveolar dead space. Is the amount of air in the alveoli, or rather the alveolus, that doesn't undergo gaseous exchange. That is called the alveolar dead space. A dead space is the volume of air in your respiration system that doesn't undergo gaseous exchange. You see, this 150 ml of air that remained in the trachea and the bronchus won't undergo gaseous exchange because here we don't have the alveoli. That's why it's a dead space. Again, in the alveoli, some of the air won't actually diffuse into blood. That's why we call it the alveolar dead space. Now, anatomical dead space plus alveolar dead space should give you what we call the physiological dead space. Anatomical dead space plus the alveolar dead space is called physiological dead space. But we usually say that in a normal physiological apparatus, if someone is normal, absolutely normal, then the patient won't have an absolute dead space. Let me repeat. We usually say that if a patient is healthy and normal physiologically, perhaps they won't have the alveolar dead space because the alveolar is totally healthy. Then you expect to have complete diffusion of air from the alveoli to the blood. Now, that's why they usually say that in a healthy person physiologically, the anatomical dead space is equal to the physiological dead space, because now for these patients, the alveolar will be 0. That is it. So another question, you'll be asked in an exam, calculate the alveolar minute ventilation. Now, the alveolar minute ventilation, from the name alveolar, is the amount of air entering the alveolus. And I think we have agreed that it is 350 ml of oxygen, of air. So we have said that 150 remains in the anatomical dead space, while only 350 enters the lungs. So alveolar minute ventilation is the amount of air that reaches the alveolar in 1 minute. So the question will be as follows. I want you guys to calculate this question. Can you kindly do this question? Roy, a 23-year-old man, was admitted at KNH. Or rather, Roy, a 23-year-old man, attended Dr. Dean's clinic for a respiratory examination. Upon running a spirometry, or rather, let me not go to the spirometry. The normal tidal volume of Roy is 500 ml of oxygen per minute, per breath, sorry. Let me repeat. Roy, a 23-year-old man, has gone to see Dr. Dean. Now, Dr. Dean is examining me, right? Now, throughout that examination, it has been found out that Roy has a tidal volume of 500 ml per breath. The anatomical dead space of Roy is 150 ml of oxygen, of air, sorry, per breath. The question then becomes, calculate the alveolar minute ventilation if Roy has 15 breaths per minute. Let me repeat. Roy is a 23-year-old man. I've gone to see Dr. Dean. Dr. Dean is doing for me a respiratory exam. He finds out that my tidal volume is 500 ml, while my anatomical dead space is 150 ml. The question then becomes, calculate the alveolar minute ventilation of Roy if he has 15 breaths per minute. So someone has actually done it here. Yeah, amazing. The answer is 5.25 liters, or 5250 ml per minute. That's how we actually do these calculations, guys. But if the question tells you calculate the minute ventilation, just like that, minute ventilation, just take 500 by 12 or 500 by 15. But if they specify the alveolar, now take the amount of air that's entering the lungs minus the dead space, then you multiply by 12. That is how we usually answer these questions. Yeah. So I'm going to send a document that was compiled by Manasseh. Manasseh was a BSc graduate. I compiled a very wonderful document on respiration and the kinds of questions that you can expect in an exam. I'm also going to share my slides, and I'm going to also send the recording. Yeah, so at this particular point, I think I'm done. There's something I need to do. So in case you have any questions, kindly take time to just reach out to me in my inbox via WhatsApp. Don't worry, guys. I'll try as much as possible to do the other practicals. So I'm also having a very tight schedule. Yeah, but I'll try as much as possible to do other practicals. Probably on Friday, we can have another session, maybe on vision, hearing, or blood, or whatever. I'll tell you about it during the course of the week. But guys, I just want to encourage you that don't give up. You still have time. 2 weeks is enough for you to make a change. Keep on reading. Keep on doing everything that you can to make things happen for you. Read as much as you can, because the last few months are going to determine you going to third year. So don't really sleep. Just continue reading, and God is going to help eventually. So thank you so much for attending the meeting. I want to end the meeting for all of you guys. In case of any questions, I'm always free. Just reach out to me. Have a great night and all the best in the end of your preparation.